Good evening all. Welcome to the Zika virus update program jointly organized by IAP Kerala and IAP Thiruvananthapuram. As we all know, while we were trying to adjust to the new normal of living with COVID, the first case of new virus, that is the Zika virus, was identified in Thiruvananthapuram around 2 weeks back. And for enlightening us about this new virus, today we have two very eminent speakers who doesn't need any introduction to the Kerala audience. Dr. Aravind, the head of Department of Infectious Diseases, Government Medical College, Trivandrum, and Dr. A Santhosh Kumar, former HOD of Pediatrics, Government Medical College, Trivandrum, and Dr. Riaz, National Executive Board Member, IAP, as the moderator. And Dr. Santhosh sir and Aravind are also the key persons behind all the guidelines and advisories from the Government of Kerala. So before going to the academic program, I invite Dr. T.P. Jayaraman sir, President IAP Kerala, for the presidential address.
Good evening, everybody. Respected President of IAP Trivandrum and Speaker of the Day, Dr. Santhosh Kumar, Dr. Praveen, Dr. Aravind, Dr. Riaz, Dr. Johnny Sebastian, Secretary IAP Kerala, all the other dignitaries on the platform. I'm very happy to participate in this CME program arranged by Indian Academy of Pediatrics Trivandrum on the new addition to the viruses in our which we have to face suddenly, Zika virus. Actually, we were reading about Zika infections for the last 2-3 years, mainly affecting the South American continent and Brazil and all those things. But we never thought it will all of a sudden land up in our own Kerala. And as Praveen was telling, it is we had been gradually recovering, or we are getting to the adjusted to the new normal to live along with the COVID virus. Suddenly now we have to face another virus, Zika virus, and it is up to I think we have to be on alert to prevent another epidemic or endemic or whatever it is due to Zika virus. And I congratulate Trivandrum IAP for arranging a CME on such a short period. Thank you, IAP Trivandrum, and thank you, Praveen, for inviting me to inaugurate this session. And I wish the very best for the program. Thank you so much.
Thank you, sir. Next, I invite Dr. Johnny Sebastian, Secretary IAP Kerala, for his felicitation.
Good evening, all. Respected Chair, Dr. Santhosh Kumar sir, Vibrant Secretary of IAP Trivandrum, Dr. Praveen, IAP Kerala President and my leader, Jayaraman sir, National EB member, and my good friend, Dr. Riaz, esteemed speakers of the day, dignitaries, seniors, and my dear colleagues on this platform. At the outset, I would like to express my heartfelt gratitude for inviting me for this webinar and for offering the felicitations today. As we all know, Zika virus can manifest in many ways. In most of the cases, there are no symptoms, but in a few cases, it can be dangerous as well. So today we have a very good speaker, Dr. Aravind, and a great teacher, Dr. Santhosh Kumar sir, to enlighten us more about this virus. I wish this seminar all success. Thank you. Jai Hind, Jai IAP.
Thank you, sir. Now we move on to the academic program. I invite Dr. Riaz for starting the academic program.
Thank you, Dr. Praveen. Respected Jayaraman sir, the President of IAP Kerala, Santhosh sir, President IAP Trivandrum, as well as my teacher, Dr. Aravind, who needs no introduction to all of us, who has been teaching us all about COVID, and now he has shifted his focus to Zika, but not leaving COVID, I know. So it's actually a very interesting part of history, which all of us are going through, I think. Because viruses, even though they are very small organisms, they are much senior to us, and crores and crores of years senior to us, and they come and visit us in many ways, and we are constantly in a fight with them. Regarding Zika, actually, these arthropod-borne viruses are known to us, and containment and all, we have a lot of experiences fighting both dengue and chikungunya. So it is not something new like COVID when we are trying to contain the disease. But regarding the effect of the disease, it is something very different, because the disease affects the pregnant mothers and then the newborn babies. And this is a virus which can survive in the gonads, or even the somewhere I read that the virus survives in the sperm for around 3 months or so. So there are many novel things about the virus itself and about the disease. And we're still not sure whether it causes any serious disease in adults as well as in older children, leaving alone the neonates. So to enlighten us in all these issues and to face the new virus, we have Dr. Aravind as well as Santhosh Kumar sir in our midst. And I invite Aravind to start with the deliberations. Praveen, isn't it? Aravind is talking first, no?
Yes.
Okay. So over to Aravind for especially we being pediatricians, we are worried about how our neonates may be affected. What is the percentage? Like, should we prepare for a more number of cases coming in like that? So over to Aravind for his deliberation. Thank you.
Good evening, respected Jayaraman sir, Jonas Sebastian sir, Santhosh sir, Riaz sir, my dear friend Dr. Praveen, and all members of IAP. I'd like to thank IAP for this opportunity. So I will start the proceedings, and the pregnancy part as well as neonatal aspect will be covered by Santhosh sir. Start slide sharing. The slides visible?
Yes, visible.
Okay, so it's a clinical update for all the clinicians. So what we are seeing on the right is actually the Zika dashboard by CSIR IGIB, which shows a clustering around Kumarapuram area. But then you can also see that we have had cases from almost all parts of Trivandrum. So we had from Shastamangalam or Pothankode, and then Poonthura, as well as from Parasara. So probably we are having multiple pockets of infection with Zika virus. So as Riaz sir said that, the flyvirus, we are now very familiar with the members of the flyvirus, the family. That is, we are familiar with dengue, the Japanese encephalitis, West Nile virus, and chikungunya in Kerala. It's a single-stranded RNA virus, and it is actually primarily transmitted through the bite of Aedes species mosquito, Aegypti as well as Albopticus, which are both of them are prevalent in Kerala. So it's an ideal scenario for Zika to root in Kerala. So the epidemiological triad, the agent was what was lacking here. The agent, the host, as well as environment is here, as well as we jokingly refer to as the epidemiological tetrad also. We need to have the right test also. So without the right test, you won't be able to diagnose any emerging infection, and that is probably what resulted in a delay in, say, around 2 months in diagnosing Zika in Trivandrum itself. So when we look at the origin, so almost all the zoonotic infections trace its origin to the primates in Africa. So during the yellow fever surveillance in 1947 in Entebbe in Uganda, so they identified this virus in rhesus monkey, and then this is what happened after that. In 1952, so the human infection was documented in Tanzania as well as Uganda in 1953. So the virus was isolated from a person in Nigeria in 1953. And interestingly, in 1954, ICMR did a zero surveillance in India, including the Madras province. So they found that they looked at the neutralizing antibodies against Zika, and they found that around 16.5% of the samples, around 550 samples were tested. 16.5% of the samples in 1954 in India had this neutralizing antibodies against Zika. So it was widely thought that there are two phylogenetic strains or clades. So one is the African, that's the East African, as well as the West African, the variant, as well as the Asian variant. And till 2007, there had been isolated or sporadic case reports from Africa as well as Asia, but we never had a major outbreak of Zika in either in Asia or Africa. It was in 2007 during the first major outbreak occurred in the IAP Island, it's a Pacific island with Zika. It's probably some mutation occurred, and it is actually something is a strain which diverged from the Asian lineage, which led to the first outbreak in IAP Island in 2007. And interestingly, 73% of the population got infected in IAP Island. And then the next major outbreak occurred in French Polynesia in 2013 and 14. So it is during the French Polynesian outbreak that there was an association, the major association with Guillain-Barré Syndrome was noted during this outbreak, and there was a retrospective evidence of microcephaly as well. And during French Polynesian outbreak also, around 70% of the population got infected. And then what happened is that from the French Polynesia, it's the Pacific Islands, so the participants went to Brazil to participate in some rowing competition, and 2014-15 onwards, the Brazil had a major outbreak. So they had around, say, 2.5 lakh cases, and people say that if you look at the zero surveillance data, more than 1 million patients got infected, and it is during the Brazil outbreak that there was a conclusive evidence that Zika virus infection pregnancy can lead to microcephaly as well as a host of other congenital malformations. And also we got more evidence of the tie between, or the association between Guillain-Barré syndrome and other neuroinflammatory syndromes with Zika during the Brazil outbreak. And then it spread through from Brazil, it spread to the entire South America as well as Central America, and luckily to the North America as well. And that is why we are having very, very good guidelines from USA. And then in February 2016, WHO declared it as an international emergency. I mean, sort of an international emergency, because around 99 countries got affected. And then after that, we had outbreaks in India as well. First from Gujarat in 2016-17, that period, and then from Rajasthan, Tamil Nadu, as well as Madhya Pradesh. So maximum cases we had was during the Rajasthan outbreak, around say 160, 170 cases, and around say 60 pregnant ladies were also affected. And it is said that the outbreaks which occurred during that I come to next slide. So this figure actually is, shows as a dark shades are where from where active cases has been reported, and the light shades are from where this in the 2015-16 where active transmission was not there, but then the zero surveillance data from 1950 onwards it show evidence of Zika virus endemicity. And this is a very important slide. So the dark brown actually represents the areas where the Zika virus infection has been associated with neurological complications. You can see that neurological complications has been reported only, it is a microcephaly or association with GBS has been reported till date only from infections in the South America, Central America, North America, as well as in Pacific Islands. Whereas in Asia, from Thailand and Vietnam, we do have say around 4 to 5 cases of microcephaly, etc. But altogether from Africa as well as Asia, usually the Zika virus has not been linked to microcephaly or has not been linked to Guillain-Barré syndrome. It is believed that it is due to the lack of the presence of two mutations, that is the S139N as well as A188B, which actually gives more transmissibility as well as the neurovirulence to the strain. So usually the strains which have led to outbreaks in India as well as in Singapore, etc., lack these mutations. And this is how the phylogenetic tree will look like. You are having the Asian lineage as well as the African lineage. It is actually from the Asian lineage that the outbreaks. So it is actually it diverged out of the Asian lineage. That is the virus which led to the outbreaks in the Pacific Islands as well as the what you call as the Brazil variant is actually something which has diverged out of the Asian variant itself. So the basic difference between the strains which have led to the outbreaks in India as well as Singapore, etc., from the strains which led to the outbreak in the French Polynesia and Brazil is probably the presence of these two variants, S139N and A188V, which actually gives more neurovirulence to the strains which lead to the sort of outbreak of microcephaly as well as GBS associated with Zika in Brazil. But having said that, now we have sequenced the isolate from Trivandrum also, and unofficial reports say that it has got 99% homology with the Rajasthan variant. And Rajasthan variant, in India, there are two variants circulating. One is from the Gujarat, which has a link to the 1966 Malaysian variant, that is the Asian lineage, and one which was identified in Rajasthan, which actually is phylogenetically close to the Brazil strain, but does not have the features of major neurovirulence. So this is actually a distribution of Aedes aegypti as well as Albopticus. Now we look at the routes of transmission. So the most commonest obviously will be the bite of an infected mosquito. Then obviously there is a maternal fetal transmission, and then there is sexual route including vaginal, anal as well as oral sex. Then it can get transmitted through blood transfusion, organ transplantation, and through lab exposure. Now, when you look at the transmission dynamics, this RNA has been detected not only in blood, it has been detected in urine, semen, saliva, female genital tract secretions, CSF, amniotic fluid, and breast milk. And in blood, the most interesting aspect is that during pregnancy, the RNA will be present in blood for a longer period of time compared to a non-pregnant patient. So in Zika virus during pregnancy, it has been detected, RNA has been detected in serum as late as 107 days. Usually when you are ordering the PCR, in the serum, the virus will be detected up to 7 to 10 days, but usually when the symptoms is less than 7 days, we are ordering the PCR. Whereas in urine, the persistence of the RNA will be more for a longer period of time. So maybe up to 6 weeks may be present in urine. So, if you are doing the urine PCR, it's from the symptom onset, 14 to 20 days, you may be able to detect the virus. So, most interesting or most important aspect is the persistence of this the virus in the semen. So, we have had reports saying that from the semen, it has been isolated as late as 188 days. But then, just like the RNA shedding in the COVID-19, so studies have shown that after 1 month, it is usually not infective. So that is. So even if there is RNA persistent shedding in the semen for say 3 months or so, only 4% of cases it will be infective. Usually after 30 days of illness onset, the virus cannot be cultured in cell culture medias. And usually when the viral load is more than 7 log RNA copies per ml only, then this becomes infective. So even though in the semen the virus may be present for 3 months or in some studies 6 months, usually after 1 month the virus cannot be cultured. The rest is just shedding. So the sexual transmission of Zika virus as late as 41 days after a partner's onset of symptoms has been described. So this is actually very, very important from a public health perspective. And from endocervical secretions also this RNA has been detected. And also up to say means 91 days it has been detected in saliva, and in 30 days in tears also. So from majority of the secretions, this viral RNA has been detected. Now with regard to the sexual transmission, CDC says that the men should wait at least 3 months after symptom onset or last possible Zika virus exposure before unprotected sex, and women can have unprotected sex only after 2 months, whereas WHO differs in that. WHO says that both the men and women should wait for say 6 months to have unprotected sex. So that is, this guidance differs from that of WHO, which suggests that men and women outside areas of Zika transmission who have traveled to areas with active transmission should wait for at least 6 months following the return before unprotected sex, regardless of symptoms. It's very, very important. And when we look at the symptomatology, this is actually from the initial cohort in Yap Island. You can see that usually the patients will have a maculopapular pruritic rash 90%, a fever will be there in 65%, arthralgia is there in 65%, and non-purulent conjunctivitis in 55%. So these are the usual 4 features which are present in patients with Zika virus infection. That is a maculopapular pruritic rash from day 1 onwards, the low-grade fever, arthralgia, and non-purulent conjunctivitis. Other symptoms like myalgia, headache, retroorbital pain, edema, vomiting, etc. also may be there. And we know that majority of the areas where we had Zika outbreaks, in those areas, like say the Brazil and all, they did have co-circulation of other flyviruses like dengue and chikungunya. In the Trivandrum scenario, Thiruvananthapuram scenario now, we are having co-circulation of dengue, chikungunya, Zika, strep typhus, leptospirosis along with COVID-19. So yeah, if you don't have access to the PCR, clinically means the easiest way will be to look at it like a mild chikungunya. So Zika is just like a mild chikungunya. So when we talk about the presence of fever, dengue as well as chikungunya, there will be high grade fever. So usually it will be more than 38.5 degrees Celsius, whereas in Zika it is a low grade fever. The myalgia and arthralgia compared to dengue and chikungunya, it may not be, it is there in Zika, but it is not that debilitating. The edema of the extremities, so edema of the feet as well as the upper limbs are there only in Zika. Then presence of maculopapular rash, which is actually more prominent in Zika compared to dengue and chikungunya. In Zika, the rash usually starts from day 1 onwards, and just like in chikungunya, it is a pruritic rash. The presence of retroorbital pain is there in dengue as well as Zika. Then presence of conjunctivitis is non-pleural conjunctivitis with hyperemia. Conjunctival hyperemia is something which might help you differentiating Zika from chikungunya and dengue. Chikungunya, it is present but not to the same extent as in Zika. The presence of lymphadenopathy is there in all 3 flyvirus infection. Hepatomegaly is there only in chikungunya. And when you look at the labs, the leukopenia and thrombocytopenia is more predominant in dengue and chikungunya, and usually Zika, the counts are likely to be normal or maybe having a mild thrombocytopenia. Presence of hemorrhage or shock will point towards the diagnosis of dengue. So this is how the Zika rash will look like. So it is a it starts from the face and extends to the body, and it will involve the palms and soles from day 1 onwards. It is a pruritic rash, and you can see the non-purulent conjunctivitis as well as edema of the the polyarthralgia. The arthralgia in Zika is usually limited to the small joints of the the hand as well as the lower limbs. Small joints are involved in a symmetric fashion, and then you can see the edema. And then certain clues, as you can see on the left side, you can see the icterus with the conjunctival hemorrhage. It is actually a classical feature of leptospirosis. Whereas if you look at the eye in Zika virus infection, you can see the non-purulent conjunctivitis with rash with conjunctival hyperemia. And when you look at the rash in dengue, in Zika, the rash will start from the onset of fever itself. Some cases, there will only be rash. So from day 1 onwards, you are going to get rash in Zika virus infection. Whereas in dengue, you have the febrile rash, which starts by around say day 3, and you have the convalescent rash, which begins after defervescence. And you can see the convalescent rash in dengue. You can see the islands of white amidst the sea of red. And if there is a gum bleeding, etc., it is not Zika. It is more likely to be dengue. Whereas in chikungunya, the rash is maculopapular pruritic, just like in Zika, but usually starts by the day 3 of fever in chikungunya. So this is one of our patients with diagnosis Zika. You can see the maculopapular rash. So any patient with fever and a maculopapular rash and a polyarthralgia and a conjunctival congestion during this period of time, so you need to consider Zika as one of the diagnoses. And Zika, Zika can also present as uveitis also is one report from NEGM. And the most important aspect is that around 80% of the patients will be asymptomatic. So from a public health perspective, it is very, very important. So 80% will be asymptomatic, and the incidence of Guillain-Barré syndrome or prevalence of Guillain-Barré syndrome is actually 2.4 per 10,000 patients affected with Zika virus infection. This is actually very, very important. And when we look at the adverse fetal outcomes, from the symptomatic mother as well as from an asymptomatic mother, there is a chance of a fetal infection, and there is always a chance of microcephaly. So what percentage of patients, what percentage of the fetus born to an infected mother will develop microcephaly actually differs from report to report. So initially, Brazilian reports pointed to the fact that if infection occurs during first trimester, 54% will develop some sort of a congenital malformation, especially microcephaly. And then if it occurs during second trimester, around 50%, and if it occurs during third trimester, it is 29%. But then these high figures were not collaborated by studies done in USA and all. Now the figures from USA state that if you get infection if the mother gets infection during the first trimester, around 12%, might get the microcephaly, and if the mother get infection during the second trimester, around 4%, and third trimester around 3%. So if you take pregnancy altogether, around say 6 to 8% are likely to develop microcephaly if the mother is infected. And say any sort of congenital malformation, if you are looking like that, around 11 to 14% likely to get infected. But as of now, data from Singapore, they had around say 500 cases, and from Southeast Asia, etc., except from 3 reports of microcephaly from Thailand and Vietnam. So, we have not had any case of microcephaly or say Guillain-Barré syndrome associated with the Asiatic lineage prevalent in Southeast Asia as of now. Now, looking at the neurological complications, the association with Guillain-Barré syndrome was established for the first time in French Polynesia, and usually they used to have a background rate of around say 3 cases per year, and during 2013 they had around 42 cases. So that is 20-fold increase in Guillain-Barré syndrome, and the proposed mechanisms were supposed to be genetic evolution of the virus to a more pathogenic genotype. That was true. That is, neuroviral mutations were there. Then susceptibility in the Polynesian population, that was proved wrong next year when they had problems with Guillain-Barré syndrome in entire South America. And one interesting aspect is a sequential arboviral immune stimulation. So this concept was put in by Halstead, who was behind the concept of antibody-dependent enhancement in dengue. What he postulated was that, since Zika is also flavirus infection, suppose you are having dengue IgG and you are having a Zika infection, there is a chance of antibody-dependent enhancement, but it has not been proven in any animal models as of now. And then, so the features of Guillain-Barré syndrome, the prevalence, incidence of GBS was around say 2.4 per 10,000 cases of Zika. And the type of the Guillain-Barré syndrome was the axonal variant, that is the Aman type. And the recovery with the post-Zika GBS was better than compared to the GBS following other infections. And the reported viral syndrome and the onset of neurological syndromes, it was a mean of around 6 days. And this figure actually shows that during the outbreak in French Polynesia, so there was a 20-fold increase in the incidence of Guillain-Barré syndrome in French Polynesia. And this is the data from Brazil also. The association was, with GBS was noted in Brazil. The incidence of GBS was 9 to 19 times higher than expected during the outbreak period. And you have the data from Colombia, Dominican Republic, El Salvador, Honduras, Suriname, all showing that there is an increased incidence of Guillain-Barré syndrome following Zika virus infection. So basically, it was thought to be higher in males than females and consistently increased with age. And you have other neuroinflammatory disorders like say ADEM as well as myelitis, myeloencephalitis, and myeloradiculopathy, and all those things associated with Zika virus infection. So you have broad differentials, especially in Thiruvananthapuram. You have dengue, chikungunya, leptospirosis, malaria, rickettsia, and all those sort of things. And probably, of the differentials, the mildest one will be Zika virus infection. But the problem is Zika virus infection occurring in pregnant ladies, which might lead to microcephaly as well as other malformations. And when you look at the lab aspect, we should know this. The incubation period is anywhere between say 3 to 14 days. And usually the period of viremia is around 2 to 7 days. And if the patient is symptomatic, within the first 7 days, you are supposed to send the serum for PCR. And then the antibodies, the IgM antibodies will start rising by the end of the first week and beginning of second week. And IgM can persist for more than 1 year. And that is the reason why, you're looking at Zika IgM to find an association with a past infection, not IgG, because IgM can also persist for longer periods of time. But the problem in looking for the Zika IgM is that the IgM can cross-react with other flaviviruses like dengue as well as Zika. So you need to follow this IgM with a print assay. So our scenario, so we do have access to the Zika PCR. There's a trioplex PCR which looks at dengue, chikungunya as well as Zika in the same sample, and the monoplex PCR, that is, which looks at Zika alone. The samples, the trioplex kit can also identify the Zika from serum sample, urine sample, amniotic fluid, plasma as well as CSF. And for doing the Zika IgM and print assay, we have to send the sample to NIV Pune. For example, you are having a baby born with microcephaly, probably doing the PCR is, we have to do the PCR for the mother as well as the neonate, but the PCR is likely to come as negative. And in order to say find causation, you need to send the sample to NIV Pune. They will do the Zika IgM, and if it is positive, they will do the plaque reduction neutralization. Then that is a print assay. So symptoms less than 7 days, we should send serum PCR. More than 7 days, up to 20 days, the urine PCR may be positive. As of now, NIV has not given sanction to do urine PCR, but our labs are capable of doing urine PCR using the trioplex method. And the testing categories for all the suspected cases, we should be doing the, that is any patient with a rash, fever, with or without arthralgia, as well as non-purulent conjunctivitis, we should be doing the trioplex or the monoplex PCR. But if there is a dearth of test kits as of now, our focus has to be on the high-risk population. The high-risk population obviously is going to be the pregnant women. So symptomatic pregnant women in the last 3 months, so it should be tested. Suspected case in family neighborhood in the last 3 months should be tested. So there are fetal radiological abnormalities definitely should be tested. Pregnancy with related adverse outcomes like IUD, congenital Zika syndrome, etc. should be tested. Travel to an area with ongoing transmission should be tested, but unfortunately we are living in an area with ongoing transmission. That is going to be a problem. Sexual contact with a confirmed or probable case has to be tested. Neuroinflammatory syndromes like GBS or transverse myelitis, so has to be tested. And so regarding blood transfusion, we know that it can be transferred through blood, but should we be screening for all the donors in Trivandrum? Actually, it is not actually possible. We don't have that much of kids. So the thing is that even if we are getting infection, the infection during the between a pregnant lady getting infections between before 20 weeks is going to be a major problem. So if antenatal the mother requires blood transfusion before 20 weeks, ideally, so the blood bank has a plan to screen for the donor. And regarding another situation post transplantation, so through the organs also, you can get infection. So post transplantation also, if blood transfusion is required, it will be better if you screen the donor and give blood transfusion. And we have very good algorithms from CDC. There is an approach to diagnostic testing for dengue and Zika virus infection symptomatic pregnant women who have got risk of infection to both the virus. That is in a Trivandrum, that is situation. So symptoms within 3 months, you do both the PCRs for Zika as well as and the dengue. Also you send blood for Zika as well as dengue IgM. If it is positive for PCR is positive for dengue, it is dengue. If it is positive for Zika by PCR, it is Zika virus infection. It is negative for both the PCRs, and then you have to send the IgMs for both. And suppose the IgM is positive for dengue as well as Zika, then you have to do the print assay. Based on the print assay, if the plaques are more than 10, they say it is dengue, and if it is more than 10 for Zika, you say it is Zika. As of now, the print assay will be done only in NIV Pune. And this is with regard to the testing recommendations for a symptomatic pregnant woman with possible Zika virus exposure. So what they do is those females who reside in endemic areas, like say pregnant lady in Trivandrum, so there is a asymptomatic infection accounts for 80% of infection. So definitely symptomatic women will have to be screened. But what about asymptomatic women? What CDC says is that we need to screen them at 3 time points. One is during the prenatal visit, and then one thing during the second trimester. So 3 times, asymptomatic pregnant lady has to be screened. It's very important. Now coming to the case definition, a suspect case is a patient with skin rash or temperature more than 37.2 degrees Celsius with one or more of the following symptoms. That is arthralgia or myalgia, non-purulent conjunctivitis or conjunctival hyperemia, headache, malaise. To travel to an area with ongoing transmission of Zika, the Guillain-Barré syndrome not known to be associated with other diagnosed etiology, or a complication pregnancy. A confirmed case is a case which has been proven by PCR. Now, epidemiology linkage. What do you mean by epidemiology linkage? Travel to an area with ongoing Zika transmission, sexual contact with a lab-confirmed case of Zika virus infection, a receipt of blood or blood products within 30 days, organ transplant within 30 days of symptom onset, association time and place with a confirmed or probable case. So, local transmission is defined as lab-confirmed case of Zika virus disease who has not traveled from an area reporting confirmed case of Zika. So, in Trivandrum, we are having a local transmission as of now. Then the next aspect is with regard to the most important aspect, that is during Brazil and retrospective in French Polynesia, there has been association with microcephaly. So, and that is what makes the thing a bit tricky. So, dealing with this thing, the infection, pregnancy, as well as the malformations we need to expect in the neonate. And Santhosh sir will be dealing with this aspect, that is Zika virus infection, pregnancy, how to screen the antenatal mothers, as well as the malformations in neonates. So thank you for patient listening. I will stop here. Thank you very much.
Thank you, Dr. Aravind. As usual, it was a lucid presentation on various aspects of Zika. A very important point highlighted is like there are a lot of differentials which we have because we are having infections of all these viruses, dengue, chikungunya, as well as scrub and leptospira, which can have similar or overlapping features. So a diagnosis, either PCR or serological diagnosis, becomes important in this case. So we will have the discussion after the next session. Now I invite our Santhosh sir to deliberate on the prenatal diagnosis as well as postnatal diagnosis as well as any interventions in the newborn baby. Over to you, Santhosh sir. Slides കാണാം സാറേ
കാണാമോ
കാണാം full screen ആക്കാമോ സാർ
എനിക്ക് സ്ലൈഡ് മാത്രമേ കാണാവുള്ളൂ മറ്റേ യെസ് സൈഡിൽ വന്നു ഓക്കെ ഇത് ഫുൾ സ്ക്രീൻ ആയില്ല അല്ലേ
ഫുൾ സ്ക്രീൻ ആയില്ല സാർ ഇപ്പൊ ശരിയായി സാർ ഇപ്പൊ ശരിയായി
Good evening. Thank you for the invite. Only thing is a short notice I be and I had to rush from the other Zoom. And it is very difficult to have a session after Aravind because നമ്മളെ സ്റ്റുഡൻസ് ആയിരുന്നിട്ട് ഇപ്പോൾ എൻ്റെ ടീച്ചറായിരിക്കുന്ന 2-3 പേരിൽ ഒരാളാണ് അരവിന്ദ്, ശിവകുമാർ ആൻഡ് നവീൻ, to name a few others. Thank you, Aravind. It was very comprehensive presentation, and you could have actually gone on with the rest of the presentation also. Okay, I'll have a very brief discussion on Zika in children. It is still under evolution how to go about in public health perspective. So there may be changes in days to come. So Zika virus, as Aravind already said, is a neurotropic virus that particularly targets neural progenitor cells, which means it may not be that damaging to the mature neural tissue. And GBS, as we all know, is a slightly different issue. It's a post-infectious phenomenon. So in the virus as such, is less likely to damage the mature neural tissue as compared to immature one. And immature one means this neural progenitor cell means the damage will be from the root, and whatever is not formed cannot be transported as well. So there will be migration problems and actual destruction of the neural tissue. Symptoms in child is exactly what Aravind has already described, but I just tell the students only 3 things: rash, pains, and fever. Rash is red conjunctiva also I include in the rash, and pains means headache, muscle pain, joint pain. So it will be easier for the student to recollect. So I usually tell them these 3. If you clinically suspect chikungunya, but it is too mild to be a chikungunya and your test is negative, then think of Zika, as Aravind said. Now, GBS, of course, there is clustering of GBS following this viral infection, but whether the clustering actually applies to the child, I do not know. I have not come across such literature. And of course, it is one of the many causes of GBS, and many causes are unknown, as we all know. And what test to do for a child is RT-PCR within the first 2 weeks, preferably the first week. And no VTM is required, unlike COVID. Actually, for a long transport, you need dry ice, but now that it is tested within the city, the ordinary ice is enough. And we have two things available, triplex and monoplex. Triplex test all the three, and monoplex only Zika. So generally we test for dengue and chikungunya, and if it is negative, then we go for the monoplex. Antibody may be tested at the end of first week, and it must be repeated after the second week, maybe at the third or maybe even fourth week, to look for a fourfold rise. PRNT is a sophisticated test which is not available with us. It's available only in Pune, where we actually detect neutralizing antibody, which means you inoculate serial dilutions of your antibody containing fluid and see whether the virus is neutralized. That is, the plaques formed is reduced or not. So that is the ultimate test of antibody efficacy also. So when we find an antibody, we cannot say it is against corona or Zika. So unless we do the PRNT. Virus persists longer in the pregnant. The causes are many. One is that in the pregnancy is a situation where we tolerate a foreign material, that is the fetus. It is actually foreign, and the body is tuned in such a way that T1 response is attenuated and T2 is predominant, so that the fetus is not excluded from the body. So persistent maternal viremia at least partially is due to viral application in the placenta, and then it is going up and down, that is to the fetus and to the maternal blood. Maternal infection leads to placental infection and injury, followed by transmission of the virus to the fetal brain. Because it is a neurotropic virus, it may particularly like the progenitor cells or the immature brain cells, where it kills the neuronal progenitor cells and disrupts neuronal migration, differentiation, and thus the brain growth is slowed down. Naturally, the size of the head also will be low. Baby with suggestive symptoms. What are the suggestive symptoms? Up to 40% microcephaly was reported in Brazil, which is unusually high. Usual quoted values outside Brazil is only about 6 to 8. So we do not know why it is so high in Brazil. Maybe it is a particularly neurovirulent variety, genetic variant of Zika there, or whether there is some problem with the denominator, because 80% is asymptomatic. So if the denominator is not all denominator is not picked up, the value may be falsely inflated. And we do not know the background rate of microcephaly, whether it itself is high in Brazil also, I do not know. Indian outbreak in Rajasthan and Madhya Pradesh, no microcephaly has been reported. So that way we are a little comfortable. And as Dr. Aravind said, the evidence so far of our genetic workup is that it is more like Rajasthan variant. But we should not give a publicity to that. Let the mosquito work go on, so that the dengue that is expected this year may not be there. Now, the other problems in brain would be like calcification, which is supposed to be in gray-white junction, which is typical, but as we all know, typical things are very rare. And as compared to the other one, for example, CMV, it is periventricular, in toxo, it is punctate here and there. Then ventriculomegaly, it is more of more because of lost brain matter rather than a hydrocephalus. And then corpus callosum agenesis, hypoplasia of the cerebellum. In the eye, microphthalmia is rare. More common would be retinal problems. Cortical visual impairment also is possible because brain is basically, if it is involved, then naturally that can occur. Retina, the typical chorioretinitis of intraocular infection that we are familiar with, not we, the ophthalmologist is familiar with, is not very common. It is more like macular scarring and retinal mottling. That is what is described. And then there can be hypertonia, which we are likely to pick up because the amyloid angles that we look for will pick it up. And cognitive abnormalities may be a late manifestation. For example, the child may be born with a normal head, but later we may detect cognitive abnormalities. So that means that just because the head size is normal doesn't mean that everything is okay and it is child is not affected. We cannot really say that. And seizure disorder, because there was brain matter destruction, and naturally that place is taken up by gliosis, glial tissue proliferation, and naturally that can act as a irritant focus and produce seizures. Hearing, naturally we are not going to miss because of Shalabam program. We are screening each and every baby. Growth retardation can be prenatal and postnatal because prenatal growth retardation is possibly because of the placental insufficiency. So you have both the body and the head both are low, so symmetrical. Or you can have a retarded growth of the brain and a near normal growth of the body. So asymmetric also is possible. And postnatal growth retardation of brain is also, as I mentioned earlier, if you have a damaged brain, it can grow less. Arthrogryposis, because suppose we have an arthralgia in the postnatal period, the joints will move less. So if the same thing is happening to the fetus may not move. So it will be born with a fixed joints. And stillbirth is also possibly because of the placental insufficiency, and abortion, any intrauterine infection, whether it is Zika or something else, can cause abortion. Risk of vertical transmission is there throughout pregnancy, but as Dr. Aravind said, maximum in the first trimester and least in the last trimester. But still it is not zero. And another unfortunate thing is asymptomatic mothers can also transmit infection to the fetus. Fetal disease is not related to maternal viral load or symptoms or pre-existing dengue antibodies, because they are related viruses, flaviviruses. There may be a partial protection by dengue antibody. That was what was thought of, but such a protection is not demonstrated in the vertical transmission. And there are reports showing that the vertical transmission up to 65%. And there are reports showing much less percentage. And also there are reports that babies had virus transmitted but not affected. So that is the big confusion in that area. And as we said, later transmission can result in a near normal head circumference, but the head may not grow the way it should. And so the so-called acquired microcephaly is also probable. And as I said, proportionate and disproportionate microcephaly is possible. That is already described. And differentiation from torch is not easy, but suppose we find hepatosplenomegaly, then it is unlikely to be Zika. It is more like torch. And also dysmorphic facie is also less likely in Zika, unless you take that receding forehead also as a dysmorphic facies. That is part of microcephaly. But dysmorphic facies, as we understand, is unlikely in Zika. Breastfeeding, it is demonstrated. I don't know what Riaz is going to say about it. It is actually demonstrated in breast milk, but not documented to infect or pass on the infection. Even if an infection is passed down, it is a postnatal infection, and postnatal infection is mild, and it is unlikely or not shown to cause CNS damage as in the intrauterine. But my own point is we must tell the mother these things, and we'll give the freedom to the mother to take the decision. For example, if somebody asks, it is a 28 or 29 weeker, can I give breast milk? Is the brain is still developing? There is no hard and fast rule on that. There is no real answer to that. So the best thing is for the mother to take a decision. Because in HIV and hepatitis B also, we have been counseling mothers giving directly counseling rather than allowing them to take a decision. We must tell them these are the things and you can take a decision. Placenta gets infected. We know placental barrier is traversed, but no placental inflammation or cellular death is demonstrated. It's not important for us clinicians, but for those who look at the histopathology, it may be important because these things are consistently seen in other intrauterine infections. Now, suppose the Zika is suspected, baby is sonologically normal, whether we should go ahead with amniocentesis. The problem is one, amniocentesis need not always yield positive results. That is one thing. Second thing, after infection of the mother, it takes some time for the placental infection to be established and then go to the fetus. And then the fetus should excrete it in its own urine. And good urine output is less likely below, say, 18 or 20 weeks. So amniotic fluid may not be full of organs. So it is very likely that you may miss. So you may have to actually go on and repeat the amniotic fluid study. So even if you find it in amniotic fluid, it is not a gas. Suppose the baby is sonologically normal and you find the virus in the amniotic fluid, it really doesn't help. We do not know whether the baby is going to get affected or not. So basically, we are putting the mother to more and more of confusions. So whether the amniocentesis is to be done or not, actually let the mother decide, because even after amniocentesis, we may not be able to give a right counseling on the decision to terminate. So when there is a maternal infection, what to do? The thing is, asymptomatic infection can also spread the disease. So there is a point that you may not suspect infection in the mother. So the most important thing is make sure that anomaly scan is done for each and every pregnancy. So much so, if there is some abnormality found, then we can possibly work up retrospectively. Yeah, suppose you have a history of or a suspicion of maternal Zika and nothing is found in the fetus on ultrasound. Again, it is a dilemma what to do, because it takes time for microcephaly to develop, and the eye finding, for example, microphthalmia is rare. It is all retinal, which is definitely not going to be detected by ultrasound. So we may not be able to detect. So the most important thing in counseling is we are not seeing the damage as we have seen in Brazil. So that is the point that we must give to the mother for her to, or help her to take a decision before doing something with a sonologically normal child. Suppose in Brazil, where they tell you that if you are infected, there is a 65% chance of brain abnormality, then even a normal child may be aborted. But in our place, I think this point we must tell the mother, and that will help her take a decision. And what to do with routine work. Delivery points must keep a register of anthropometry of all newborns and stillbirths. As Aravind is mentioning repeatedly, we must measure the head circumference of stillbirths also and see whether it is appropriate to the gestational age. If not, then it must be sent for investigation, placenta, cord, cord tissue and fetal tissue of the abortus. But what are the things to be sent, that we will decide as per government directions. That directions have not come, in which cases we have to keep these tissues, or whether we have to keep this tissue and send. For histopathological examination, naturally our formalin is needed, but for the virus isolation, we don't need preservative. We have to send it as such. So what to do now that we have cases in Trivandrum? One is syndromic surveillance, suspect and test if pregnant, because our test kits are limited. We cannot go on testing each and every suspected case. And it is possibly not necessary also, because apart from pregnancy, it is a very mild disease. And verbal screening, like a visit to the place or a contact with a person who has come from place where there is active transmission of recent, because that we can get only from time to time. You cannot get it from, say, history of Zika in that particular place in a particular period of time. At this particular point of time, whether the virus was spreading at that place. And targeted surveillance of delivery and GBS cases, of course. And mosquito control is the most important. And the message to the public is that there is no need for undue concern. So with that, I'll end my presentation. Thank you.
Sir, can we stop share?
Let me see. Stop. Okay.
Actually,
Yes.
yeah, okay. Thank you, sir, for emphasizing the point that there is no need of a very what you call a lot of concern. We need to follow. We need to be in the watch out. But as of now, there is nothing to worry much about. But we need to follow. I think there are a few questions in the chat box. We will go to the chat box first, and then we will have direct questions, whatever. The first question, I think, is to Dr. Aravind. Is itching present in all cases of Zika? Essential criteria?
No, itching is not present in all cases of Zika. Occasionally, itching will be present. Yes.
Actually, itching is more in chikungunya, much more in chikungunya.
Okay. And whether measles also comes as a differential?
Measles also might come as a differential, but then, sir, no, measles, that the classical look and all, from clinically we will be able to diagnose measles.
That is true, but now we have cases, non-classical cases of measles.
Definitely. So measles, rubella, because if you look at the outbreak which happened in the private hospital, initially they thought it is rubella, because patients were having mild fever with mild arthralgia and the posterior cervical knots, and there was a clustering like that, especially in females. So all sorts of DDs were there. Now they sent all the multiplex PCR, everything came as negative, and only then after that they thought of sending to Pune.
And where all in Kerala IgM antibody is done? And also please tell about how reliable is serology, whether we should go for PCR.
Actually, there is a problem of a cross reaction with all the other fly viruses. As of now, this IgM should be coupled with print assay, and print can be done only in NIV. So we are supposed to send samples to NIV Pune for IgM as well as print assay. This situation occurs especially if we are having an IUD or say a microcephaly and the PCR is likely to be negative, a Guillain-Barré syndrome. To find the association, we need to send the IgM to Pune, and if IgM is positive, they will do the print assay to find whether it is due to Zika or not. And interestingly, as part of the WHO dengue study, Sri Kumar sir and Rajiv Gandhi did do the print assay for dengue for us, And if he gets a live strain of Zika virus, he'll be able to do print assay in Zika as well.
And this transport will be facilitated by the district authority, isn't it, Praveen? Like if there is a case, whom
Yes,
to
yes.
contact, or like for if needed to send to an AV.
Yeah, the samples are transported via the DM office in every district.
Okay,
Actually,
so
even samples to medical college should be routed through DMO.
okay, so Praveen, can you provide some number or whatever, like how?
Oh, Trivandrum, I can give the number in chat box.
Okay, okay, so we can give it in the chat box. Okay. Then can we get a false positive Zika if a patient is having COVID or during post-COVID period?
That is actually for us to do research on, because it's the first time an outbreak of Zika has happened along with a COVID setting, so we should do. But one thing we should keep in mind, there have been reports from last year onwards that the structural protein of dengue can cross-react with that of COVID. So if that is possible, definitely it can cross-react with Zika also. So it's a very good area for us to study.
Santhosh was telling that the asymptomatic mothers can also pass on the virus to the baby, and baby can become diseased. So is it good that you screen all pregnant women for Zika in Trivandrum?
Actually, that should be a public health decision. So you cannot go on screening each and every person for each and every disease. So in this particular case, for example, neurological problems are starting, then possibly this is extremely important. But as of now, it looks more like an Indian strain, as Dr. Aravind said. It looks more like a Rajasthan strain. In which case, we are really not expecting much of a neurological, not really much. They have, am I right, Dr. Aravind? They have not detected any microcephaly in Rajasthan and Madhya Pradesh.
That is true, sir, but then they had only around, say, 42 pregnant ladies to follow. And in Singapore also they had around 4-5 cases, but the number of pregnant ladies were less. In Brazil, they started noticing because they had around 2 lakh cases, diagnosed cases, sir. And ICMR is the only scientific body who conclusively said in 2018 and 19 that this strain will not lead to microcephaly. And actually, international media did criticize ICMR because no, we cannot just rule out neurovirulence by certain mutations, because it is an RNA virus and the proofreading mechanism is defective. So it is capable of picking up new mutations. But as of now, the sequence strain from Trivandrum is having 99% homology with the Rajasthan strain. So as of now, we might be in a safe zone. But then our surveillance should go on. Suppose one of our microcephaly, the neonate, is having a Zika IgM positive, and then the print also says it is Zika, then everything will go, and we have to go with the CDC protocol of screening all the the pregnant ladies in an endemic area have to be screened thrice during their pregnancy. That is CDC protocol. That we have to set in motion only if we have conclusive evidence. As of now, we are on a safe side.
So connected with that, Dr. Sija had raised a concern. It is too early to dismiss this small outbreak as innocent, even before gene sequencing of the virus is available. Most mothers will be worried about the serious outcome because the neuronal damage is going to continue even after birth for 1 year. And also she had asked whether we need to isolate all these pregnant mothers as well as newborns who are tested positive, because their body fluids, all body fluids may contain the virus. And whether we need to follow up all babies for neurodevelopment, vision, hearing, musculoskeletal system. So comments from the experts.
Yeah, do these mothers need isolation until virologically negative?
Yes, sir.
I think virologically negative means RT-PCR may remain positive, as we have seen in COVID. So that is a never-ending isolation. It will become a never-ending isolation. And I think unnecessary worry to a pregnant lady is more damaging than the Zika. So let them be more comfortable with the available information. So the available information is it is possibly not going to do big damage, but those who got affected, we will definitely keep under follow-up and do everything. But all the other normal people who are residing in Trivandrum, they should not panic. And isolation for a long period of time during pregnancy itself is a stress to both mind and body. So I would prefer not to do that. Aravind, your comments?
Agree with you, sir. And the first part of the question was, have we dismissed the outbreak as innocuous even without the sequencing result? We have not done that. The only thing is that with the available evidence, the literature from India over the last Rajasthan and Maharashtra outbreak, and that from Southeast Asia, and knowing that our strain is having 99% homology with the Rajasthan strain. So as of now, probably everything boils down to risk communication. What we need to say to the public. So as Sar said, then if we say all the pregnant ladies, then they are at risk and all those things, then it might be counterproductive, knowing that our strain may not be having neurovirulence. Having said that, our focus has to be on very good surveillance, looking at all the IUD, measuring the anthropometric parameters, having a registry of GBS, looking at the GBS numbers over the previous 6 months, looking at the microcephaly of the previous 6 months, trying to find an association. And if we are able to find an association, definitely it becomes a major concern for us. Yeah.
Actually, in SAT, we have sent some 40 microcephaly patients for whom we couldn't find a cause for this Zika in Rajiv Gandhi, and we couldn't find a single one. But the problem is we have been sending urine, because urine is the one that has got a longer period of excretion of the virus as compared to serum. And even that may have the time limit may have gone. So whether it is because of that we did not know. But we didn't get a single positive.
This was previously, isn't it, sir? Not,
yes,
not
yes.
for this episode.
Before Corona.
Before Corona. And Dr. Sri Prasad is asking if we find something positive in the anomaly scan, what next?
Whether it is Zika or not, when you find some anomaly in the scan, then it is not for us to decide. We will tell them this is the finding at the scan, and these are the possible causes. And if the child is born, these are the things that is going to happen. And then it is for the mother and the family to take a decision. It is not for us to take a decision.
Okay. Thank you, sir. Dr. Anju is informing us that there were around 34 positive cases, around 170 samples tested in our district as of today. And another concern is getting both dengue and Zika positive. Is it about a co-infection, or is it antibody positivity? Anju, can you clarify that? Are you thinking about a co-infection, or whether the antibodies?
Actually, co-infection has been documented if both the PCRs are positive. Just based on the IgM, we cannot say it is a co-infection. So, because in print also you can have, dengue plaques as well as chikungunya plaques. That is why they count the number of plaques and decide whether it is Zika or dengue. So, regarding the antibody-dependent enhancement, studies are going on whether the antibody-dependent enhancement can occur with dengue followed by Zika or Zika followed by dengue. So as of now, in the studies on macaques published in 2020 says that there is no evidence of antibody-dependent enhancement, but further studies are actually needed. And ours is an interesting area. We are having Zika, dengue as well as chikungunya. So whether it can lead to antibody-dependent enhancement and all, as of now there is no evidence.
I find PMCs are in the group. Sir, anything regarding newborn? Sir. So there are no more questions in the chat box. Praveen, if anybody wants to ask a question directly, you can unmute.
Yeah, everybody is unmuted.
If there is a question, please unmute and ask.
Turning positive. Zika, after how many weeks we can go for blood donation? Aravind sir.
Blood donation. Okay, blood donation. Actually, the guidelines with regard to blood donation are not clear cut. So I'm not in a position to say that. So what you have decided is that, so they usually take a history of 3 months. No, within 3 months, if there is any history of fever with rash or something like that, they have decided not to take the blood. So whether it will persist for longer periods of time, that I am not pretty sure. The only blood transfusion regarding guidelines which is going to come in the state is an antenatal who requires transfusion prior to 20 weeks, then the donor will be screened. So, and because it is because we have only paucity of kits, antenatal transfusion, that is less than 20 weeks, the chance of them recurring transfusion is less. So definitely those people will be screened. The donor PCR will be done, and if only negative, the blood will be collected. Otherwise, there will be a syndromic screening also. In the last 3 months, if there is fever with rash, probably blood won't be taken. And post-transplant scenario also, that it is going to be an elective transfusion. In such situation also, in post-transplant patients, since they are immunocompromised, there is a possibility of complications, even though myocarditis, etc., are pretty rare. In that situation also, donors are going to be screened. But if the question is an exact period, is it 3 months or 4 months, I am not in a position to say, sir.
Sir, one more question. It can be transmitted through sexual route also. So
Yes,
if
yes,
it
yes.
is positive, how long to avoid, or after how?
CDC says for males 3 months unprotected sex should not happen, and females 2 months. WHO says 6 months for both.
Our policy?
Our policy means we have only CDC and WHO data to bank upon, sir. So it has to be either 3 months or 6 months. No, we have not decided, and ICMR and the guidelines are not there on that aspect.
Are we facing a state guideline, Dr. Aravind?
Sir, means so yes, sir. So the only thing is that the CDC says 3 months and WHO says 6 months. No, at least 3 months is required, because the studies have shown that even though there is a persistent RNA shedding in semen, after say 1 month, it has not been cultured in cell culture media. So 3 months will be fine. Need not be 6 months, because the WHO 6 months also comes with a rider sort of thing. They have said that it's not 6 months for everyone like that. So a minimum of 3 months, that should be fine, sir.
Any mortality with Zika, not about GBS, the acute infection anywhere?
There has been reports of myocarditis, sir. But mortality, I'm not really aware of mortality. But then along with GBS, in the French Polynesian, mortality was 10%. But still it was less than GBS following other infections.
Yes, Anju.
Sir, I have read that, sir, in children also mortality was reported, but only in those with the comorbidities like sickle cell anemia, malignancy, etc., sir.
Thank you, Anju. Is there any increase in number of GBS cases after this or during the period? Praveen, any idea from the district?
No, sir, I was also thinking about the GBS, because most of the GBS we have also attributed to Covishield also. So we should rethink whether these were due to Zika or not.
Actually, it's a problem, because COVID can lead to more GBS than Covishield, and Zika probably can lead to as much number of GBS as COVID. So it's going to be a major problem for us.
So can we go back and check the cases of GBS for Zika? Will it be possible?
Actually, we should be doing that, because the state has a plan of having a retrospective registry like thing for GBS which occurred in the last 6 months. So if we can trace them and do some Zika, IgM and PRND as well, it is going to be worthwhile. Not point in doing urine PCR and all those things. So we have to do on Zika, IgM and PRND.
That may help in removing the bad name of Covishield also sometimes.
But the temporal sequence we can't dismiss, sir. Okay.
Okay. Okay. So any more questions? questions or comments or experiences? There are many IAPs who have joined from other parts of the state also. So any similar cases or fever, rash? If there are no more questions, I thank profusely Dr. Aravind as well as Santhosh sir. I think sir was attending 2 meetings back to back. So thanks for enlightening all of us. And I declare the academic session closed and over to Praveen.
Thank you, Dr. Aravind and Santhosh sir, for the excellent presentation and excellent discussions. Thanks also to Dr. Riaz for moderating the session, and I also thank all the participants who attended today's program. Thank you. I think we can wind up. Thank you.
Thank you, Praveen.